corticoid therapy if it is given for long term and at large doses. Whatever the type of diabetes, all of you have to know how you are going to manage a woman with an already established diabetes. To start with, before embarking on any pregnancy, those pregnant ladies affected with diabetes should attend a preconception clinic to receive appropriate preconception counseling. The counseling process should include stressing on a healthy lifestyle, including healthy weight management, encouraging diet and exercise, avoiding alcohol and cigarette smoking. It is very important to stress during the preconception. طبعا هيدا أحكي سريع لأن هو الموضوع أعتقد it is familiar يعني most of you are familiar with this. Although if you have any questions you can ask me and stop me at any slide. Here during the preconception period it's very important to strict on good glycemic control. Why? Because it has been found there is a very strong correlation between an elevated hemoglobin HbA1c level prior to the pregnancy or early during the pregnancy with an increased risk of miscarriages and increased risk of congenital deformities in their fetuses. Therefore, if any woman with diabetes found to have an elevated HbA1c, and as you know, it reflects the blood glucose status within the previous 3 months, should be encouraged to postpone their pregnancy and should be offered a method of contraception of good contraception until their glycemic control become optimized. As well, it is very important to stress on the intake of high-dose folic acid at a dose of 5 milligram daily, which has been found to reduce the risk of neural tube defects of their fetuses. Because as you know, diabetes is associated with an increased risk of CNS deformities or anomalies or malformations. But this risk has been found from the studies and trials that it is much significantly reduced with folic acid supplements at high dose 3 months prior to the conception. That should be continued for the first 3 months during a pregnancy. For those women with long-standing diabetes and having coexisting medical illnesses, if they are kept on medications that are potentially harmful to their babies, for example, if they are hypertensive and taking some forms of angiotensin converting enzyme inhibitors or statins, or any other drug that might be teratogenic to their fetuses. These medications should be shifted to a safer alternatives in the preconception period or during the preconception period. For example, if they are kept on captopril, they should be shifted to another safer medications, examples, methyl-dopa or whatever. Statins should be stopped, etc. And it is very important during the preconception period to screen for the diabetic complications, for the possibility of any diabetic complication, those especially in those with a long-standing diabetes, that is to say those with insulin-dependent diabetes mellitus. These complications should include screening or searching or looking for the presence of microvascular disease, macrovascular disease, retinopathy, nephropathy, and neuropathy.
دكتورة استاذين له بديل بالحامل؟
لا ما لها بديل. Anti-lipids should be stopped during pregnancy.
دكتورة بلال زحمة ممكن سؤال؟
تفضل عيني.
Why you should give high dose of folic acid supplement?
مواني قلت those women with diabetes, especially if it is uncontrolled, will be at increased risk of neural tube defects, malformations, for example, spina bifida, anencephaly, etc. And from the studies, it has been found that folic acid, if it is given at high dose 3 months prior to conception, prior to the pregnancy, and continued for the first 3 months throughout their pregnancies, that is to say throughout their first trimester, this has been found that it significantly reduces their incidence or risk of neural tube defects. Okay? For the retinopathy, okay, retinopathy, as you know, it means retinal changes that is related to the duration of diabetes. Therefore, any woman with long-standing diabetes should be screened for the presence or absence of retinopathy, and if it is found, should be dealt with and treated appropriately. And here it is important to know that, unfortunately, with rapid improvement in glycemic control, there will be a worsening, or their retinopathy will be worsened, and an already existing retinopathy with rapid improvement will be worsened. So it is better to offer gradual control of their blood sugar values in order to avoid worsening of an already existing retinopathy. Therefore, those who found to have retinopathy should be offered appropriate method or mode of contraception until any measure that is required is carried out, for example, laser coag treatment, etc. Although during a pregnancy, if retinopathy is found and laser therapy is required, it can be carried out safely during a pregnancy. Here it is important to stress on the continued retinal screening, not just during the preconception period, but again via the fundoscope or that is carried out via an ophthalmologist. Screening should be offered again during a pregnancy. And this is better to be done at the booking visit, which is the first antenatal visit while she is pregnant, and then offered again when she is pregnant at her 16th up to 20 weeks gestation, and again screening should be offered at the 28 weeks gestation. For the diabetic nephropathy, the important information here is that any progression in, or any deterioration in renal function that occurs during pregnancy usually reverts to the pre-pregnancy levels after birth. But unfortunately, the higher the pre-pregnancy creatinine concentration, there will be the higher the risk of permanent loss of renal function. And it has been found in the presence of significant proteinuria, that is to say more than 2 grams per 24-hour urine collected, there will be a high risk of preeclampsia development. And the risk will be increased by about 2 up to 4-fold. As well, the risk of preterm labor will be increased in those women with significant diabetic nephropathy. Lesser degrees of proteinuria, that is to say less than 2 grams per 24-hour urine, will be associated with increased risk of pregnancy-induced hypertension. And neuropathy is a problem as well, especially if the autonomic nervous system is affected, because this will blunt the adrenergic and metabolic response to hypoglycemia. And as you know, hypoglycemia is associated with an increase in the counter-regulatory hormones, which are the cortisol from the adrenal cortex, glucagon from the pancreas, adrenaline from the adrenal medulla, growth hormone. All of these responses will be blunted in those with autonomic neuropathy, especially in patients with long-standing diabetes. Therefore, the hypoglycemic attacks might be frequent and severe in those women. For patients with signs and symptoms or who are suspected to have macrovascular disease and suspected to have a premature coronary heart disease, those women should be referred to a cardiologist in order to screen for the presence or absence of these possible complications. Other maternal complications that should be discussed with the patients prior to embarking on her pregnancy, that she should be informed about the increased risk of infection, of severe hyperglycemia, of diabetic ketoacidosis, as well the complications that may arise from increased operative delivery rate. طبعا DKA is increased يعني the attacks of severe hypoglycemia and severe hyperglycemia both are increased and because with regard to the hypoglycemia مثل ما عرفتوا انه because of the autonomic neuropathy that may be present, but with severe hyperglycemia these attacks as well is more likely to occur because of the enhanced maternal lipolysis during a pregnancy, and it occurs even at lower blood sugar values. Of course, the operative delivery rate is increased as well. The risk of having a cesarean section is increased because of the macrosomic babies and associated fetal morbidities, especially in those women with uncontrolled DM. So what are the pre-pregnancy guidelines for a good glycemic control? So احنا قلنا هاي complications كلها might happen. واحنا قلنا it is very important to stress on achieving euglycemia during the preconception period يعني قبل ما يعني تحبل الأم. Then what are the targets? For the HbA1c, it is better to be kept below 6.1%. For the fasting blood sugar, below 5.5 millimole per liter. طبعا تعرفون انه شلون نحولها للمليغرام بير ديال مو؟ احد يعرف شلون تتحول هاي الوحدة او القراءة الى مليغرام بير ديال؟ اكو احد يقدر يجاوب؟ وياي؟ تسمعون؟
وياك بس ما نعرف.
ما تعرفون. طبعا تعرفون
نضربها في 18
بالضبط. اي الجلوكوميتر هو القراءة ما تغلب يعني تنطينا بالمليغرام بير ديال، فلازم تعرفون شلون تحولون. ف 5.5 يعني ضربوها في 18، كل قراءة تنضرب في 18 يعني تنطينا القراءة بالاكويفالنت ان مليغرام بير ديال. فال 5.5 تصير 99 وهكذا. For the 1 hour post-meal glucose value, it should be kept below 7.8 millimole per liter. يعني 7.8 إذا ضربوها يطلع 140 تقريبا مليغرام per ريال. Of course, this is based on احنا شلون نسوي وشلون نحقق ال strict euglycemia. Can we achieve these targets by the use of oral hypoglycemic agents? ايش تتصورون؟ يعني إذا a woman already kept on oral hypoglycemic agents because she has, for example, the non-insulin type dependent diabetes mellitus. نقدر نحقق هيجي strict يعني glycemic control؟ ما نقدر. يعني ما عرفت وياي أو لا، المهم ما نقدر نحققها with the use of oral hypoglycemic agents عادة. Although يعني the oral hypoglycemic agents is not associated and there is no evidence that shows an increased risk of teratogenicity with the use of oral hypoglycemic agents. يعني مو مثل ما تتصورون مثلا الداوني أو السلفونيل sorry زيد الريسك of teratogenicity in the affected fetuses. لا، مو لهذا السبب، هو أساسا ماكو evidence إنه there is an increased risk of teratogenicity, but the shifting to insulin therapy is for the sake of better glucose level control to achieve better euglycemia. For the metformin, it can be continued throughout pregnancy. هسه احنا خلصنا من ال preconception period. The mother becomes pregnant. How we are going to deal with those women affected with diabetes? Starting from the first trimester, all of those women should be referred or should be followed up in a combined multidisciplinary diabetic obstetrician antenatal clinic. These clinics should include obstetricians, diabetologists, specialized midwife, diabetic nurse, dietitian. طبعا هاي ideal situation. And here it is very important to emphasize on the importance of the value of an early ultrasound scan that should be carried out between her 6th up to 8th week gestation for two purposes. For first of all, to confirm fetal viability, because as I have said to you that there will be an increased risk of fetal losses, especially in those women with uncontrolled diabetes mellitus, as well for accurate dating. because especially in those women with diabetes, there will be an accelerated fetal growth later on during their pregnancies. Therefore, confirming the gestational age from the beginning or from the start during early first trimester is very important. As well, it has important to screen for the presence or absence of diabetic complications at the booking visit, which is the first antenatal visit that is carried out during the first trimester. These complications, as I said, include diabetic retinopathy, nephropathy, and here it's important to know that it has been found that if the measurement of albumin creatinine ratio and serum creatinine level revealed an elevated values, these women will be at increased risk of preeclampsia development during their pregnancy. Therefore, blood pressure should be monitored and measured frequently throughout their gestation. As well, in the presence of significant proteinuria, that is to say more than 2 grams per 24-hour urine collected, or in the presence of an elevated serum creatinine above 120 micromole per liter, ومثل ما تعرفون الأبر normal value for serum creatinine should not exceed 107 micromole per liter. Here, aspirin or heparin should be considered in order to reduce the risk of preeclampsia, as well to reduce the risk of uteroplacental insufficiency later on in their pregnancies. For the diabetic autonomic neuropathy in the first trimester, if it is present, this will increase the risk of gastroparesis. That is to say, there will be a much more delayed gastric emptying. As well, this will increase the risk of hypoglycemic attacks, مثل ما ذكر سابقا. Screening for the non-diabetic maternal comorbidities should be carried out early during the first trimester. شو نقصد بالcomorbidities? For type 1, for those women with type 1 diabetes mellitus, the comorbidities might include other autoimmune diseases. And the guidelines recommend that all women with type 1 diabetes mellitus should be screened for thyroid disease, while other autoimmune diseases should be screened for if it is clinically indicated. يعني شنو؟ يعني من نشوف علامات أو أعراض other autoimmune diseases we should screen for. مثلا شنو الexamples؟ أعطوني examples إذا تعرفون of SLE عافية بعد.
celiac.
نعم celiac disease أحسنتي بعد. نعم pernicious anemia, rheumatoid arthritis وهواية أخو multiple sclerosis. فكل هذول if clinically يعني if there is a clinical manifestation of any one of these autoimmune diseases, they should be screened for. لكن الثايرويد disease لا, it is recommended to screen all women for the presence of autoimmune thyroid diseases اللي هي تعرفوها مثل الهاشيموتو's thyroiditis والgraves disease. With type 2 diabetes mellitus, the comorbidities هي شنو؟ obesity, hypertension, dyslipidemia. زين. What are the another important thing that should be done during the first trimester? First trimester follow-up should include screening for chromosomal anomalies. And this is done by measuring NACALA translucency at the 11 up to 12 weeks gestation. And as well, if it is increased, it might indicate an underlying diabetic related malformations, يعني غير الchromosomal anomalies. Examples اللي هي structural malformations of the heart. اللي هي مثل ما تعرفون uncontrolled diabetes is associated with increased risk of congenital abnormalities, especially those affecting the cardiovascular system in the form of endocardial Cushing defects mainly, or those affecting the CNS, central nervous system. Of course, first trimester follow-up should include assessment and optimization of glycemia. مثل ما قلنا ال DKA develops more quickly in pregnancy and at a lower blood glucose values due to enhanced maternal lipolysis. From the start, those women should be advised on the prevention of hypoglycemic attack. طبعا الهايبوغلايسيميا مثل ما تعرفون it is by itself it is not harmful to the fetuses يعني مو معناتها الطفل will be affected لكن المشكلة وين إنه it might be occasionally life threatening for the woman. زين إحنا شلون ننصحها إنه تتجنب الهايبوغلايسيميا؟ من خلال إنه we have to teach her about the signs and symptoms of hypoglycemic attack. ونقولها يعني لازم تخلين ببالك إنه مثلا أكو أوبرا جلوكاغون يمج أو some sweets يعني نعطيها علامات الهايبوغلايسيميا مثل ما تعرفون هي الhunger, sweating, palpitation, and anxiety, etc. So what are the targets؟ يعني احنا حتى نتجنب الهايبرغلايسيميا والهايبوغلايسيميا والincreased risk of congenital abnormalities ونتجنب كل مشاكل الدايابيتس during the first trimester. فشنو what are the targets that should be achieved for good glycemic control؟ مثل ما قلنا تقريبا هي نفس التارجتس that has to be reached during the preconception period اللي هي شنو؟ For the glycosylated hemoglobin, it should be kept below 6%. For the fasting or pre-meal values should be kept between 3.5 up to 5.5 millimole per liter. طبعا بالمناسبة أنا إذا أسألكم الهايبوغلايسيميا عادة at which level it develops؟ يعني من نشيك blood sugar values ونشوف إنه يعني هذا الليفل هو تقريبا below لا مو 60 below 53
below 80
لا below 53 هاي نعتبرها تبدي تصير life threatening يعني جوال 53 ملغ per dl. زين for the 2-hour postprandial levels the 2-hour postprandial value should be kept between 4 and 6.5 millimole per liter. وإذا تتذكرون من السلايدات السابقة ال1 hour value وش قد قلت لكم لازم يصير جوا وش قد level مالتها ال upper limited level allowed 7.8 مليمول per liter. وإذا تضربوها بال 18 راح تصير حتى تحفظوها بعد ساعة من الوجبة it should not exceed 140 ملغ per dl وبعد ساعتين من الوجبة it should not exceed 6.5 اللي هي يساوي 117 تقريبا ملغ per dl يعني roughly 120. اوكي زين هسه what are the important points that should be followed up during the second trimester? Again, optimization of glycemic control is very important, especially during the middle of the second trimester. Why? Because there will be an increase in maternal insulin resistance due to the high concentration of circulating maternal fatty acids and placental diabetogenic hormones. Then, what are the placental hormones that are considered to be diabetogenic? يعني شنو الهرمونز اللي هي تؤدي إلى increased peripheral insulin resistance؟ هي حقيقة كل الهرمونز أغلبها من ضمنها placental estrogen, placental human placental lactogens, cortisol, whatever. During the second trimester, it is very important to screen for the presence or absence of congenital deformities. Because as you know, the ideal time for detailed anomaly scan is carried out between 18th and 20 weeks gestation, and for fetal echocardiography, it is better. It is the time for echocardiography or for examination of the heart, fetal heart, is between 20 up to 22nd week gestation. فهو هذا the time for detailed anomaly scan. As well, other obstetric complications should be screened, and her blood pressure should be monitored frequently because it is the time for preeclampsia development. لأن تعرفوا من الليكتشرز السابقة بصف رابع إنه ال preeclampsia is a disease or a disorder of the second half of gestation. Fetal growth as well needs to be followed up, and the assessment for fetal growth should start at the end of the second trimester and repeated every 1 month, 4 weekly until 36 weeks gestation. As well, the amount of amniotic fluid should be assessed and measured because an increased amount of amniotic fluid, يعني polyhydramnios, as well as excessive fetal growth might be a complications of an uncontrolled diabetic state. With regard to the third trimester, again, optimization of glycemic control is very important. During the third trimester, many women might be at a risk of threatened preterm labor and may require administration of glucocorticoid therapy, corticosteroids in the form of dexamethasone or betamethasone, for the sake of enhancing fetal lung maturity. And because these drugs, as I said, is diabetogenic, therefore it has been found that the dose of insulin needs to be increased by about 40% for the next 72 hours from the initial starting dose. Fetal growth needs to be followed up مثل ما قلنا كل 4 أسابيع by measuring the abdominal circumference and comparing it to the head circumference or biparietal diameter. Because the rising ratio between abdominal circumference percentile in relation to the head circumference or biparietal diameter, this will be an indicative of an accelerated fetal growth. زين هسه احنا ليش نقول ايش عجب يعني راح يصير عندنا يعني في disproportion between the head circumference in relation to the abdominal circumference, and there is an excessive fetal growth. يعني ليش ما الكل الجسم يتضخم في بنفس المقدار ونفس الدرجة؟ اكو واحد يعرف يقدر يجاوبني؟ اوكي، ما تعرفون. حقيقة مثل ما تعرفون الماتيرنال هايبرغلايسيميا تؤدي إلى شنو؟ تؤدي إلى fetal hyperglycemia as well، لأنه الجلوكوز is transferred from the mother to the baby، بينما الأنسولين ما يعبر البلاسنتا تعرفون. فايش راح يؤدي إلى increased fetal insulin secretion from the fetal pancreas. والفيتال insulin أو الانسولين by itself يعتبر a potent growth factor. فيؤدي إلى شنو؟ يؤدي إلى excessive growth and excessive fat deposition within the abdomen and within the viscera, especially the liver, heart, but there will be a brain sparing effect. صحيح؟ فلذلك the growth will be accelerated in those with fetuses or women with uncontrolled diabetes. طبعا any concern during the third trimester of fetal well-being، يعني إذا we suspect the possibility of fetal compromise, these fetuses should be followed up with a Doppler assessment as well as cardiotocography.
دكتور هنا اللانك ماتشوريشن يعني قصدي من مال فيتس؟
اي طبعا، ليش ولا ما تحتاج
يعني دكتورة شنو لازم نعطيها يعني روتين دكتورة؟
لا مو روتين، احنا قلنا during the third trimester those women with uncontrolled DM or any woman in general might be exposed to the risk of a threatened preterm labor. يعني شنو يعني؟ يبدأ عندها يصير مثلا spontaneous uterine contractions. For example, يعني prematurely before 37 week gestation, for example at 34. فإذا هي صار عندها high contraction، واحدة من الميجرز أو المانجمنت هي نعطيها الستيرويد ثيرابي. ستيرويد ثيرابي هاي شنو؟ شافوا أنه تزيد السيرفكتنت ريليز in the lung، فبالتالي يقل الريسك of neonatal respiratory distress syndrome after birth. عرفت؟ وبما أنه these drugs are diabetogenic، فإذا a woman with diabetes needs a glucocorticoid therapy for fetal sake، إيش راح نسوي؟ نزيد الدوز مالتها مال الأنسولين اللي هي already تاخذها بنسبة 40% for the next 3 days from the initial dose of treatment. Okay? زين.
نعم دكتور.
طبعا مثل ما قلنا البيبي usually is affected by excessive fetal growth يعني will suffer from macrosomia if the woman has uncontrolled diabetes mellitus. لكن this is not always the case. The IUGR might be a complication as well. يعني the fetus might be growthly restricted as well. شو وقت نشوفه يعني إنه it is growthly restricted with oligohydramnios في حالات إذا كانت الأم تعاني من a long-standing diabetes with vasculopathy يعني عندنا vascular disease, vascular involvement, as well in the presence of coexisting significant renal disease, and in case of preeclampsia development as a secondary complication for an already existing diabetes. فإذا إذا أحد يقول لكم إنه ممكن a mother with diabetes have or has a growthly restricted fetus نعم ممكن رغم أنه أغلب الأحيان البيبي will be macrosomic if the euglycemia is not achieved. زين وصلنا للtiming and mode of delivery. The guidelines states that it is better to deliver the woman before 39 weeks gestation and preferably between 30 at her 38 between 38 and 39 week gestation. This is because of the increased risk of late unexplained stillbirth. Okay, حتى لو كانت الwoman very tightly controlled with regard to her blood sugar values. But it is recommended not to postpone the delivery above 39 weeks gestation. زين خلوا ببالكم إنه risk of birth trauma increases with increasing birth weight. طبعا اعتيادي birth trauma نقصد بها إنه whether trauma to the genital tract or trauma to the fetuses or to the neonate while it passes through the birth canal. واحدة من one of the most important major complication is the increased risk of shoulder dystocia with increasing fetal body weight. It has been found the risk is estimated to be about 3% when the fetal body weight between 4 and up to 4.5 kg, but this increases by about up to 14%, 10 up to 14% when the fetal body weight exceeds 4.5 kg. Okay? For the mode of delivery, of course, many factors affect the decision how we are going to deliver the woman, whether via vaginal route or via cesarean section. But in general, cesarean section rate is an increase in those women with diabetes because of the increased fetal growth, because of the increased risk of macrosomia, as well because of the increased rate of failed induction, and the presence of coexisting maternal complications, for example, preeclampsia. Therefore, the rate of C-section has been found to be as high as 50%. هسه during birth وصلنا إلى مرحلة الولادة. Here, it is very important to know that achievement of hypoglycemia, يعني شنو achievement of normal blood glucose values during delivery and during the during the time of operation is very important to prevent post-delivery neonatal hypoglycemia. ليش؟ لأن مثل ما تعرفون إنه الهايبرغلايسيميا تؤدي إلى excessive fetal insulin secretion. So after delivery, when the blood glucose supply is stopped, that is coming from the mother, this will lead to severe fetal hypoglycemia. If the fetal insulin secretion is stimulated because of the higher maternal blood glucose values intra-op or during the time of birth, during the delivery process. Therefore, this is best achieved by using an intravenous insulin sliding scale. This is done via infusing 5% glucose as well as insulin, and the infusion rate should be kept according to the blood glucose values. that should be the ideal levels that should be achieved during birth is between 4 and 8 millimole per liter. So if the level drops below 4, of course the 5% glucose infusion should be increased, while if it has been found to exceed 8 millimole per liter, of course the infusion of insulin should be increased. And this sliding scale, insulin sliding scale, should be continued until the mother starts taking meals. After birth, and once the placenta is delivered, the insulin dose that the mother is kept on during her pregnancy must be immediately halved. يعني شنو؟ يعني فرضا المother أنه she had their insulin therapy for the first time during their pregnancy، مثلا وصلت إلى 20 soluble before each meals مثلا، فهاي ال20 مباشرة after delivery should be halved، نقسمها توصل يعني نخليها تصير 10 مثلا، أو إذا هي وصلت إلى مرحلة ال40 وحدة antenatally، immediately after delivery of the placenta يعني after birth these doses should be halved. لكن was taking certain doses of insulin before pregnancy, they should be returned to their pre-pregnancy values doses. يعني قبل الحمل ايش قد كانت تاخذ، فبعد الولادة ترجع إلى نفس الجرعة مالتها من once she starts their meals. What about breastfeeding? Can we give insulin safely during breastfeeding? Yes, it is safe لأنه insulin is not excreted into breast milk. However, with regard to the oral hypoglycemic agents, sulfonylureas, there is a theoretical concern that they can cause neonatal hypoglycemia. يعني they cross the placenta in a certain percentage and can cause neonatal hypoglycemia. Therefore, they are better to be avoided. With regard to metformin therapy, it can be safely continued throughout breastfeeding. Of course, we have not to forget that before discharging the mother home, we should give her an advice on a suitable method of contraception. هسه مثل ما وعدتكم إنه we are going to say something about another important category, and it is considered as a major category of gestational diabetes. So, as I said to you, it means diabetes or glucose intolerance that is first recognized during a pregnancy. And of course, this will include those women with an already established diabetes, but who were not undiagnosed. The incidence of gestational diabetes is about 2 up to 9% of all pregnancies. It affects about 2 إلى 9% of all pregnancies. طبعا احنا if the mother is strictly adherent to antenatal care and she has a regular antenatal care, نقدر من البداية نعرف إنه whether she was diabetic from the start or not. لكن إذا هي she has bad antenatal care and she did not attend the clinic early in her pregnancies, and for example, if she is presenting later on at, for example, above 20 weeks gestation, if she was discovered to be diabetic, it will be hard to diagnose or to know whether her diabetic state is presented just now or she is an already diabetic woman. What about the risk factors for gestational diabetes? Of course, increasing body mass index is an important risk factor, above 30 kg per meter square, an increasing maternal age, the presence of history of gestational diabetes in her previous pregnancy, previous delivery of a large baby, macrosomic baby, history of previous stillbirth and stillbirth. يعني من خلال الباست obstetrical history نعرف إنه هي عندها مثلا she gave birth to an infant weighing, for example, more than 4.5 kg, or she has an unexplained previous stillbirth. تقول أنا طفلي السابق مات ما يعرفون شنو السبب، يعني هو مات ببطني. كذلك من الريسك فاكتورز هي first degree relative affected with diabetes or ethnicity, especially the non-white ethnic group. What about the screening for gestational DM? حقيقة there is no single screening test that has been shown to be perfect. And for the glucose estimation, in the urine. يعني urinary glucose estimation is of course unreliable because because of the increased glomerular filtration rate. Any single attack of glucoseuria should not be regarded as significant, although repeated attacks of glucose in urine should alert an arm and necessitate further screening. So most rely on the blood glucose estimations. And as you know, oral glucose tolerance test is considered as the best screening and even diagnostic test for DM. What about the cut-off thresholds for the gestational DM after a 75 gram oral glucose tolerance test؟ طبعا سابقا كانوا يقولون ال 100 ملغ هو recommended regime، لكن حاليا شافوا انه 75 gram يكون better and it should be prescribed or it is advised to be carried out between 24 and 32 weeks gestation. شنو هي ال cut-off thresholds؟ بالنسبة للفاستنج, if it is found to be more than 5.1 millimole per liter, 1 hour value 10 and more millimole per liter, 2 hour value is 8.5 millimole per liter or above. What about the glycemic targets that should be set for gestational DM? طبعا هي the same بالنسبة لل يعني as in any woman with any type of diabetes. اللي هي شنو؟ مثل ما قلنا fasting blood glucose should be below 5.5 millimole per liter. 1 hour value should be below 7.8 millimole per liter. زين 2 hour value تتذكرون ايش قلت لكم؟ below ايش قد؟
6.
من 4 إلى 6.5 millimole per liter. زين هذا شلون؟ How can we achieve these targets? To start with, of course, we have to start with diet and modest exercise. If these does not work, we can prescribe metformin to the woman or metformin with insulin therapy if it is required. زين what about the future risk in women with gestational DM? شنو الفيوتشر ريسك؟ يعني ستجي الأم تقول ها هي دكتورة هذا السكر فقط بالحمل، يعني بعد الحمل ينتهي. أنا إيش أقولها؟ أقولها لا. You will be at increased risk of the development of type 2 diabetes over your subsequent 2 years. It has been found that approximately 50%, يعني نسبة عالية, might develop or might progress into type 2 diabetes over their next 20 years of life. Therefore, these categories of women should be encouraged on a healthy lifestyle or including appropriate reduction in their body weight, as well encouraging physical activity. Metformin can be prescribed to those women as well, and they should be encouraged to annually check their blood glucose values, hemoglobin, HbA1c, or even performing an oral glucose tolerance test. Of course, each subsequent pregnancy should be screened. مثل ما قلت لكم من ضمن risk factors for gestational DM is the presence of history of gestational DM in any previous pregnancy. What about the neonatal and longer-term consequences of diabetic pregnancy? مثل ما تعرفون, there will be مثل ما قلنا increased risk of congenital abnormalities. What are the systems that are most likely to be affected with uncontrolled DM?
Cardiovascular.
وبعد غير الكارديوفاسكولار بحيث احنا لا احنا ايش قلنا ننطي الفوليك اسيد لانه هذا ايش قلنا الريسك اوف
نيورال
سي ان اس عافيه نيورال تيوب ديفكت يعني سي ان اس السنترال نيرفس سيستم. كذلك اكو طبعا خلوا ببالكم اكو فد شيء اسمه فد باثوجنومونيك abnormality اللي هي يسموها الكودال ريجريشن سيندروم. كودال ريجريشن سيندروم يعني هذا pathognomonic of fetuses of a woman with uncontrolled diabetes mellitus. بينما most likely to be affected اكو فرق بيناتهم، يعني commonly affected هو cardiovascular system والcentral nervous system. لكن من نقول pathognomonic يعني من نشوف هذا اللي هو الكودال ريجريشن سيندروم. حقيقة ما عندي سلايد ما حضرت، بس هو تقدرون تدورون عليه من خلال جوجل سيرش. كودال ريجريشن سيندروم is pathognomonic، يعني من يشوف هذا موجود معناته the woman was her mother was the mother or the woman was diabetic. كذلك من ال neonatal consequences of diabetic pregnancy إنه there will be an increased risk of a number of transient metabolic disturbances. مثل ما قلنا ال hypoglycemia of hypoglycemia will be increased, as well as hypocalcemia, hypomagnesemia, polycythemia, hyperbilirubinemia. كذلك اعتياد risk of neonatal RDS will be increased as well، لأنه ال hyperglycemia will leads to a decreased surfactant release in the neonatal lung or in the fetal lung. كذلك there is an increased risk of cardiomyopathy in the neonate, and he will be at increased risk of childhood obesity. أحد عنده سؤال عن المحاضرة قبل لا أني أسألكم وتجاوبوني من خلال الشات، ومثل ما نزلت لكم بالستريم شلون أجوبتكم تظهر، فهذا كله يصير إكسترا كريدت لكم باحتساب السعي. زين
دكتور العفو، بس قلتينا انه مرات تكون المرضى دايابيتك ويصير الطفل انه جروث ريستريكتد. ذكرت 3 حالات، بس تقدرين تعيديهم بس احنا.
أي 3 حالات اللي هي في حالة إنه أكو عندها هي أصلاً already have the woman already has a long-standing diabetes and is complicated by vascular disease، يعني عندها vasculopathy، فهذا يؤدي إلى uteroplacental insufficiency. كذلك في حالة إنه she develops preeclampsia during her current pregnancy، والpreeclampsia مثل ما تعرفون is complicated by uteroplacental insufficiency and subsequently growth restricted fetuses. وفي حالة يعني in the presence of significant renal disease. okay. يعني في كل الحالات هي there is a vascular يعني there is a uteroplacental insufficiency. زين هسه فقط ثاني أعتقد I have to stop sharing. هي بعدها موجودة عندكم الشاشة مال سلايدات؟ زين جاوبوني من خلال الشات what are the main differences between type 1 and type 2 diabetes in general. هاي تعرفون من خلال المعلومات العامة مالتكم أعتقد. The main differences between type 1 and type 2 diabetes. جاوبوني من خلال الشات، هذا كله راح ينخزن عندي بالدرايف وأرد أرفعه لكم إن شاء الله حتى تعرفون أجوبتكم. صعب عليكم السؤال غيره؟ شو لحد الآن ما حد يكتب.
دكتور جاي نكتب بس شوية راد كتابه هواي السؤال.
يعني headlines. شنو الظاهر السؤال صعب عليكم؟ ما أدري.
دكتور أنا جاوب.
دكتور جاوبنا.
كملتوا الإجابات؟
لا جاي توصل بقية الإجابات بس الأغلب جاوبوا.
يعني على كل هسه هواية جاوبوا
دكتور بس
صحيح.
أنا من الرابط الثاني بس ما أخاف يعني ما
لا لا هي كلها تسجل، لا تخافون. الرابطة
دكتور
تسجل.
بنزح ما نشرف عندنا الباوربوينتس على المنصة هسه.
هسه في هذه اللحظة؟
يعني دكتور هسه يعني هسه ورا ما تخلص المحاضرة دا ما تصير زحمة عليك يعني.
ما يخالف، بسيطة سهلة. كملتوا عيني حتى أغلق النت؟ أكو أحد ما جاوب؟
اي نعم دكتورة بعدنا
في دكتورة دقيقة واحدة.
يلا يعني استعجلوا لأن وراكم أعتقد محاضرة ثانية يمكن بالعشرة، بالتسعة العفو.
دكتورة شوي من لحقنا.
ليش هسه هواية ملحقين؟
دكتورة احنا غير بدنا نكتب
بعد هم بدا يكتبون.
بعد. لا دكتورة مو